Good day, sir. Good day, everyone. We are here today to present to you a case study which is assigned to us, which is the acquired immunodeficiency syndrome or AIDS. So here are the members: Ms. Hernandez Kate Aguilar, and myself, Janrib Sumafranca Insoy, Kenisha May Legaspi Pangilinan, and Messi Gael C. Purmito. So here is the table of contents. So I'll be doing the introduction. This includes the objectives and the introduction of the case. So let's proceed with the introduction. So the main objective, or the general objective of this case study, is that at the end of this, the learners shall improve their understanding, knowledge, and skills in applying holistic care to the patient with acquired immunodeficiency syndrome or AIDS. And the specific objectives, the learners will be able to identify or define what is acquired immunodeficiency syndromes or AIDS. Also will be able to define or identify what is human immunodeficiency virus, and also its signs and symptoms and the stages of it, and also to formulate and provide a nursing care plan, and identify and discuss its appropriate management effectively, and lastly, formulate an extensive care for a patient with acquired immunodeficiency syndrome. So now let's talk about what is HIV and AIDS. So acquired immunodeficiency syndrome or AIDS is a chronic, potentially life-threatening condition caused by the human immunodeficiency virus. By damaging your immune system, HIV interferes with your body's ability to fight infection and disease. HIV is a sexually transmitted infection or STI. It can also be spread by contact with infected blood or from mother and child during pregnancy, childbirth, or breastfeeding, and it can also be transmitted by the means of unprotected sexual intercourse. So let's proceed with what is HIV. So HIV is a virus that attacks the human immune system and limits the body's ability to self-protect against disease and infections. So the former healthy immune system of the individual and infected with HIV can no longer protect itself from infections or the progression of the virus. The HIV targets CD4 plus lymphocytes, also known as the T cells or T lymphocytes. T cells works in concert with B lymphocytes as part of the acquired immune system. HIV integrates its RNA into host cell DNA through reverse transcriptase, reshaping the host immune system. So we will know about that later on in the pathophysiologic process. In there, we will discuss it at a cellular level, so that we will be able to know how the HIV works inside our body. So now, here are the symptoms that the HIV causes. So we have here under the primary infection or the acute HIV, you can see there fever, headache, muscle aches and joint pains, rash, and also in the clinical latent infection or the chronic HIV. In this stage of infection, HIV is still present in the body and in white blood cell. However, many people may not have any symptoms or infections during this time. This stage can last for many years, and if you're not receiving antiretroviral therapy or ART, some people develop more severe diseases much sooner. Next is the symptomatic HIV infection. So as the virus continues to multiply and destroy your immune cells, the cells in your body that help fight off germs, which is the CD4 plus and the CD8 plus T cells. You may develop mild infections and chronic signs and symptoms such as fever, fatigue, swollen lymph nodes, diarrhea, weight loss, oral yeast infection, and all. Then next is the progression to age. When age occurs, your immune system has been severely damaged. You'll be more likely to develop opportunistic infections or opportunistic cancers, diseases that wouldn't usually cause illness in a person with healthy immune system. So now let's proceed with the stages of HIV. We have here 4 stages: stage 0, stage 1, stage 2, and stage 3, or the stage where you are identified as a person with AIDS. So let's first talk about the stage 0. Stage 0 is used to represent early HIV infection. And during this time frame, the patient has a negative HIV test, but within 6 months, the patient will test positive. It is assumed the prior negative test was unable to detect the presence of HIV. The patient can transmit the disease during this time, even though the antibodies titers are negative. It can take up to 3 months for antibodies to show up on test, although they typically appear 6 weeks after exposure. So let's proceed with stage 1. The first manifestations for the disease process will occur within 4 weeks of infection. These manifestations may be mistaken for influenza and can include weakness, fatigue, headache, rash, night sweats, and a sore throat. This stage is marked by a rapid rise in the HIV viral load. It decreases the CD4 plus cell counts and increased CD8 cell counts. In stage 1, we'll have the 3 following characteristics. First is the absence of an opportunistic AIDS-defining condition. And second is the CD4 plus T lymphocytes or T cells count is 500 cells per mm³ or more. And lastly is the CD4 plus T lymphocytes percentage of total lymphocytes of 26% or more. The resolution of the initial viral manifestation of HIV infection is coincidental with the decline in viral HIV copies. However, lymphadenopathy persists throughout the disease process. Next is the stage 2, or known as the latency stage. So, as patients are noted to be asymptomatic due to the decline in HIV copies, this decline results from the body's immune system attacking and minimizing the virus, although not eliminating it completely. This stage can be prolonged, allowing patients to remain asymptomatic for 10 years or more without taking medication, and for decades if you are on antiretroviral therapy. And during this stage, anti-HIV antibodies are produced, and the patient's test for this will become positive. The viral set point is the amount of viral load remaining in the body after the immune system's effort to eliminate it. This set point relates directly to the patient's prognosis, as a high viral set point typically equates to poorer outcomes for the patient. Over time, the virus will use the host's genetic machinery to begin active replication of itself. The viral load increases and the CD4 plus cells are destroyed. This process results in a dramatic loss of immunity have that can have life-threatening consequences for the patient and are a significant concern to healthcare delivery. Um, this stage has the following characteristics. First is the absence of an opportunistic or age-defining condition. Next is the CD4 plus T lymphocyte count is 200 to 499 cells per mm cube. And lastly is CD4 plus T lymphocyte percentage of total lymphocytes of 14% to 25%. So unlike sa stage 1, mas lesser na ang CD4 plus cells pag abot sa stage 2. So, as evidenced by the decrease in the CD4 plus count and the CD4 plus percentage as compared to stage 1, the patient is experiencing a significant loss of immunity secondary to the virus becoming more active. This loss of immunity places the patient in a more vulnerable position as they move into the third stage of the disease process. So, we're now on the last stage, or the stage 3 or AIDS. In the stage 3 of the disease process, the patient develops AIDS and is at grave risk for opportunistic infections. This stage is defined through presentation of the following characteristics. So there is a presence of an opportunistic age-defining condition, and then the CD4 plus T cells count is less than 200 cells per mm cube, and lastly the CD4 plus T cells percentage of total lymphocytes is less than 14%. So patients are considered to be in stage 3 of the disease if an age-defining condition is present, even if the CD4 plus count or percentage is outside the expected range. Stage 3 is the final stage of HIV infection, and if the patient does not receive treatment, that is likely to occur within 3 years. Unlike stage 1 and 2, stage 3 is associated with a range of defining conditions. As can be seen from the aforementioned descriptions, stage 3 is associated with severe health challenges for the patient, and they are often extremely ill. The nurse should be aware of the pathophysiology of the defining conditions associated with stage 3 to plan appropriate care. Since the patient has the potential to develop more than one age-defining illness, this can present a challenge for the healthcare team when planning and delivering care. So, here are some of the complications or the age-defining condition. Here, we have here the candidiasis of esophagus, herpes simplex, invasive cervical cancer, and then next.
Here I will be discussing the profile and history of the patient. Our patient's name is Ryan, a male 19 years old and is single. Its address, occupation, and attending physician are non-contributory, as well as its source of history. The reason for seeking care. So the patient stated that he's been out of breath, he had a cough, and is feeling run down. He also thinks that he had a fever. This came on fast and is going on now for almost a full week. So for the patient's past medical history, at the very young age of 7 months old, Ryan was diagnosed with respiratory syncytial virus infection. So this was a very common cause for hospitalizations among infants. Next, at the age of 4 years old, he met an accident which is from a falling vase. So he had a forehead laceration that required stitches. Next, at the age of 8 years old, he had a seroconversion that leads to PPD or purified protein derivative. This was treated for 12 months with isoniazid. Next, at the age of 16 years old, he had a perineal ulceration that cultured positive for herpes simplex. So this was topically treated with acyclovir and zinc oxide. Next, at the age of 17 years old, he was diagnosed with oral candidiasis. This was resolved with fluconazole. At the same age of 17 years old, he got tested positive for HIV with both ELISA and Western blot test. 20 months ago, he again had a oral candidiasis that is also resolved with fluconazole. 10 months ago and 4 months ago, he had a 2 episodes of anemia. It was treated with erythropoietin. Next, 6 months ago, cytomegalovirus retinitis in the right eye. He was tested positive for immunoglobulin to cytomegalovirus and is received induction therapy with IV ganciclovir twice daily for 21 days, followed by IV ganciclovir maintenance therapy for 10 weeks until discontinued due to recurrent central line infections. Subsequent placement for intraocular ganciclovir implant in the right eye. Next, in 10 weeks, catheter line infections with 2 episodes of catheter line infections. Next, 6 weeks ago, he was hospitalized for pneumocystis pneumonia. This was developed with allergic reaction to trimethoprimsulfonmethoxazole. This was effectively treated with IV pentanamidine for 14 days and then he was discharged. So these are the findings while doing a physical exam of the patient. So for the skin examination, soft, intact, warm, and dry to touch, no visible lesions, rash, ecchymosis, petechiae, or cyanosis. For the hint, or head, eyes, ears, nose, and throat, pupils are equal, round, reactive to light accommodation, and while doing the fundoscopic exam of the left eye, reveals new fluffy, white retinal patches with focal hemorrhages consistent with cytomegalovirus retinitis. For the right eye, reveals no new lesions. Ears and nose are clear, sinuses are non-tender, and oral cavity are negative for thrushes, erythema, exudates, or lesions. For the neck examination, neck is supple with no masses or broods, slight cervical lymphadenopathy, and thyroid are normal. For the chest and lungs examination, mild axillary lymphadenopathy are observed or armpit lump are observed. Bibasilar crackles are also observed with auscultation. For the cardiac examination, sinus rhythm S1 and S2 are normal. Rubs and murmurs are observed with auscultation. For the abdomen, abdomen is soft and non-distended. Pain or tenderness is observed. Hepatosplenomegaly is also observed and bowel movements are heard, which is really normal. Mild to moderate inguinal lymphadenopathy is also observed. For the genital or rectum examination, stool guaiac test is negative, which is normal. Anal sphincter function is also normal. Visible genital or anal lesions are observed, and prostate exams are deferred. For the breast examination, breasts are small. It has a masses, discharge, retraction, edema, ulcerations, or discolorations are observed. Axillary nodes are also palpable. Spine are For the spine examination, it was tenderness to percussion. For the musculoskeletal or extremities, neuromuscular are intact. Pedal pulses are +2, pedal pulses +2, which means it only needs light palpation. Edema is observed and nails are normal with full range of motion. Ibalik ko. For the neurological examination, um, the patient is active and responsive to its environment. Babinski reflex are observed. Abnormalities in the cranial nerve is observed also. Normal deep tendon reflexes, and there are focal neurologic signs. So the normal development at this particular stage. So for the physical aspect, they have adult bodies but are not always prepared entirely for adulthood. For the emotional aspect, they feel as if they have reached the stage of full maturity. For the social changes, they value committed relationships and are developing community consciousness, and they make their own decisions.
Hello everyone, and now we are talking about the diagnostic result. So first we have HIV-EA as a screening assay for many infectious diseases, including HIV. So it means this HIV-EA is the enzymes-linked immune sorbent assay, also known as an enzyme immunoassay. So it detects HIV antibodies and antigens in the blood. So next we have P24 antigen. So it measures the viral caspid P24 protein in blood that is detectable earlier than HIV antibody during acute infection and is associated with high levels of viremia during which the individual is highly infectious. So, by the way, viremia is a medical term for viruses present in the bloodstream. And then Western blots. So this diagnostic result is a laboratory method used to detect specific protein molecules from among a mixture of proteins. And then we have qualitative PCR. So it implies viral nucleic acid to allow for its detection in patient specimens. Next is qualitative RNA PCR and genotyping. So this qualitative RNA PCR, this means that the test can tell whether or not someone has the virus very early on in their illness. And the genotyping is the process of comparing DNA sequence information to identify differences in individuals and populations. And the last is CD4 count. They are specialized cells of the immune system that are destroyed by HIV. So this is a test that measures the number of CD4 cells in your blood. CD4 cells, also known as T cells, are white blood cells that fight infection and play an important role in your immune system. So as you can see the table, that is the diagnostic result of Ryan.
So next is the concept map. So under the predisposing factors, as we can see in the patient's data, he had an unprotected oral and anal intercourse, and also with multiple intercourse partner. So for the precipitating factors, human immunodeficiency virus infection is the only causative factor for the AIDS. So now let's talk about the pathophysiologic process. So the HIV causes severe damage to the immune system and eventually destroys it by using the DNA of CD4 plus cells to replicate cell. In that process, the virus eventually destroys the CD4 plus cells. So how does the virus destroy the CD4 plus cell? So the virus, through replicating itself, it causes the CD4 plus cell to swell and burst. So that's when the CD4 plus cell depletes. So when the CD4 plus cell depletes, that means that we don't have enough army to fight off the virus. Kaya CD4 plus cell is a cell that CD4 plus cells are helper cells that activate B cells, killer cells, and macrophages when a specific target antigen is present. So yes, as I've said, when it depletes, we don't have enough army to fight off the virus. So that's when the immune system is severely damaged. Okay, we don't have enough defense to fight off the virus. So when the CD4 plus cell falls below 200 millimeter cube per cell, ma-identify na dayon na to ang person as person with AIDS. So as you can see in the laboratory test of the patient, as you can see in the CD4 cell there, under this visit column, you can see that he only had 119 count. So since it's below 200, he is already considered as person with AIDS. So these are the manifestations that he had: dyspnea, fatigue, and dry cough. For the dyspnea, the nursing diagnosis for it is shortness of breath, and for fatigue, fatigue related to infection, as evidenced by patient reporting he has feeling run down. And for the dry cough, nursing diagnosis, ineffective airway clearance. So for the intervention for the dyspnea, the first is auscultate breath sounds every 1 to 4 hours. Monitor respiratory patterns including rate, depth, and effort. And for the independent, administer oxygen as ordered. And for the fatigue, the interventions that we had for the dependent is establish realistic goals with the patient. Second is identify energy conservation techniques, sitting, breaking activity of daily life into manageable segments, keep travelways clear of furniture, provide or assist with ambulation and self-care needs as appropriate. And third is encourage nutritional intake. And for the independent, refer to physical and or occupational therapy. And for The dry cough interventions independent for the dependent encourage the client to use an incentive spirometer. Second, help the client deep breath and perform controlled coughing. And for the independent, administer medications such as bronchodilators. So this is the medication that the patient is taking. Tenofovir or 300 milligram taken orally once a day. Intercitabine 300 milligram taken orally once a day. Lopinavir or ritonavir for 400 milligram and 100 milligram for twice a day. And for ganciclovir implant for his right eye, and ganciclovir 1 gram taken orally thrice a day. Multivitamins and dapsone 50 milligram taken orally once a day. So complications. So here are the complications that a patient had: pneumocystis, pneumonia, and oral candidiasis, and cytomegalovirus retinitis.
So here I will discuss the nursing care plan of the patient together with Ms. Hernandez. So before I proceed, let me have a brief discussion about the nursing care plan. So a nursing care plan contains all of the relevant information about a patient's diagnosis, the goals of treatment, the specific nursing orders, including what observations are needed and what actions must be performed, and a plan of evaluation. So the first diagnosis we have is fatigue. So for the cues or assessment, the patient stated that he's been out of breath, he had a cough, and is also feeling run down. He also thinks that he had a fever, and this came on fast and is going on now for almost a full week. So, for our objectives for the short term observation, the client will be able to improve its sense of energy. So, at the end of our 8 hours of nursing care, the client will be able to improve its sense of energy. So, for the long term observation, it is to aid the patient with developing a schedule for daily activity and rest. So after that would be after 2 to 3 days. So for our intervention, for our independent intervention, first is to establish realistic goals with the patient. So this provides a sense of control as well as a sense of accomplishment. This will prevent the discouragement due to overactivity of exhaustion. Second is to identify energy conservation techniques such as sitting, breaking ADLs into manageable segments. Keep travel ways clear of furniture. Provide or assist with ambulation and self-care needs as appropriate. So this will protect patient from injury during the activities. So for our third intervention is to encourage nutritional intake. So this is to fulfill increased energy demands for exercise. Adequate nutritional intake or utilization is required. HIV infection causes a hypermetabolic state due to the constant activation of the immune system. So for our dependent intervention is to refer the patient to physical and or occupational therapy. So this includes daily workout and activities and are designed to assist patients to maintain and improve strength and muscular tone, as well as improve their overall sense of well-being. So for our evaluation, the patient is able to improve sense of energy. So that is on our short-term observation. So the patient is able to improve sense of energy. So our goal was met. So for our long-term observation, the patient is able to promote active participation in planning, implementing, and evaluating therapeutic management to alleviate fatigue. So our goal was also met. So the second diagnosis that we have here is cough. So for the subjective assessment, client complains a persistent and non-productive cough. And for our objective assessment, we have observed a bibasilar crackles with auscultation during a chest and lungs examination. So for our short-term observation of our objectives, client will be able to demonstrate effective coughing and clear breath sounds. So that would be at the end of our 8 hours of nursing care. And for our long-term observation, client will demonstrate airway management, airway functioning, and cough enhancement. So that would be after 2 to 3 days of our nursing care. So for our independent intervention, first we have is to encourage the client to use an incentive spirometer. So this is to recognize that controlled coughing may be just as effective as incentive spirometry. Second, we have here is to help the client deep breath and perform controlled coughing. So having controlled coughing uses diaphragmatic muscles, making making the cough more forced and effective. And for our dependent interventions, it is to administer medications such as bronchodilators. So bronchodilators decrease airway resistance and to improve the efficiency of respiratory tolerance. So for our short-term observation, the patient is able to demonstrate effective coughing. So that means our goal was our goal was met. Next, for our long-term observation, the patient is able to demonstrate airway management. So that means for our long-term observation of our objectives, our goal was also met.
One of the problems that found in the patient's profile that needs nursing care plan is the dyspnea. Its subjective data, according to the patient, he's been out of breath. And its objective data shows chest and lungs by basilar crackles with auscultation and objectives. The short-term objective within my shift and after performing nursing intervention, the patient will be able to identify and avoid specific factors that inhibit effective airway clearance. The long-term objective, after 2 to 3 days, client will maintain a patent airway at all times. Its nursing intervention, independent, auscultate breath sound every 1 to 4 hours is rationale. Breath sounds are normally clear or scattered fine crackles at bases, which clear with depth breathing. The presence of coarse crackles during the late inspiration indicates fluid in the airway, which indicates an airway obstruction. Second, nursing intervention. Monitor respiratory patterns including rate, depth, and effort. Its rationale. Normal respiratory rate for an adult without dyspnea is 12 to 16 breaths per minute. The dependent intervention. Administer oxygen as ordered. Its rationale. Oxygen administration has been shown to correct hypoxemia. Its evaluation. Goal met. The patient is able to know and is aware about the information and resources regarding his health condition. The long-term objective. Goal met. The patient is able to perform necessary procedures and explain reasons for actions after a week.
And now let's talk about the evaluation and recommendations. So prognosis of patients. So the patient with untreated HIV infection is poor with overall mortality rate of more than 90%. The average time from infection to death is 8 to 10 years, although individual variability ranges from less than 1 year to long-term non-progression. So many variables have been implicated in HIV's rate of progression. So next is recommendation to promote early prevention and treatment. So voluntary counseling and testing. This intervention enables people to know their HIV status and provides counseling support to help them cope with the outcome. So condom promotion, distribution, and social marketing vary by epidemic profile. So it is beyond dispute that the use of condom by sexual partners who are HIV discordant is extraordinary cost effective. Given the low cost and high effective of the condom is preventing HIV transmission. So next is the latest analysis suggests that STI control may be most effective as an HIV prevention strategy when initiated earlier in the cause of national epidemics and when sexual risk behaviors are high. Avoidance of unwanted pregnancies among infected mothers. So, one of the most effective strategies to reduce HIV among infants is to provide better contraception service. So, next is use of antiretroviral therapy. Evidence indicates that the provision of antiretroviral drugs to infected mothers significantly reduces vertices transmission. So, next is implementation of safety practice. So, transmissions of HIV can be virtually eliminated in health care settings through blood safety program that ensures national blood transfusion services.
This chapter discussed the evaluation and implication to nursing practice, nursing education, and nursing research in our case study topic assigned, which is the acquired immunodeficiency syndrome. The nursing practice. This case study is utilized to implement collaborative nursing intervention to patients diagnosed with acquired immunodeficiency syndrome. The information in this study are gathered during assessment to form a diagnosis and create an outcome plan for patients with AIDS. The nursing care plan will be a guide to plan, to see the problems, to implement, and to evaluate the nursing process and will be able to meet the needs of the patient. So in general, it evaluate and apply the critical thinking skill of student nurse to be able to put into practice such as in clinical settings to provide treatment to such disease. Nursing education. Acquired immunodeficiency syndrome is a matter of concern because the number of cases has increased dramatically over the last 10 years. This case study have demonstrated the beneficial effects in which it provides knowledge, attitudes, and education to the student nurse to be able to share it to the patient with AIDS for the treatment and counseling. Nursing research. This case study needs rigorous nursing research to provide a body of knowledge that helps advance nursing practice as AIDS patient needs become more complex and healthcare systems become more varied. It is a useful tool to use evidence-based care by incorporating its own nursing research with its professional experience and a patient's preferences. So it needs scientific knowledge and factual basis to be able to formulate and conduct treatment to such disease.